Our next section is seizures and epilepsy. Did you ever wonder what's the difference between those?
I thought epilepsy was a seizure. I thought seizures were epilepsy. You got seizures and my epilepsy. You got your epilepsy and my seizures.
The answer is that seizures means a generalized or partial convulsive syndrome. Epilepsy means I cannot figure out why this happened. Epilepsy means an idiopathic seizure disorder. Epilepsy means this. You had a seizure? I excluded all these things here in the vitamin story. Okay? How about this? Guy with a seizure comes to the emergency department. We're not just a room, we're a department. You have to exclude all the identifiable, correctable causes of seizures. And then, if it's negative, I get an EEG and it's epilepsy. Epilepsy means an idiopathic seizure disorder. If a guy comes in, he's got a gunshot wound to the head, that's not epilepsy. That's a gunshot wound to the head. A guy comes in and he's having a seizure. Although really the first thing to do is to treat the guy. In terms of how our notes are organized, they're organized out by looking at etiology. So in reality, the first thing to do is to squeeze this guy some benzodiazepines, and if the benzodiazepines don't work, some phenytoin or fosphenytoin, and if that doesn't work, some phenobarbital. However, in terms of organization of notes, the first thing is this. I got a simple answer for you. CNS, what can cause a seizure? What defect or abnormality in the brain can cause a seizure? And I have a very simple answer for you. The simple answer is anything. The simple answer for you about what in the brain can cause a seizure is anything. Anything can cause a seizure. Anything can cause a seizure. In other words, if you have a stroke, it can serve as a focus of electrical abnormality, and you seize. If you have a tumor, it can cause abnormalities in the electrical system. The same way if I open the breaker box to your house or open up the electrical wires for your appliances in your kitchen and I take the insulation, I rub them all together, they'll cause electrical sparks and an electrical short. So therefore, anything that causes an anatomic in the brain, anatomic abnormality in the brain, okay, a tumor, a bleed, trauma, you just have to have damaged the wires in the brain. The wires, they cross like two electrical wires touching together. A stroke, a tumor, a trauma, a bleed, anything. Now, the most important thing is anatomic problems. You'd be surprised at how many people find out that they have a brain tumor because they were standing in Las Vegas and they had a seizure. They woke up with a seizure. They got the head scanned. It's a big deal. It's a big deal first, okay? So that means automatically anybody who has a seizure has to get a CT or an MRI of his head. CT is first. If the CT shows nothing, then an MRI, because of so many anatomic abnormalities. And remember that you could have multiple sclerosis. So in other words, MS is part of the anything that's in the brain. It can cause you to have an abnormality that results in a seizure focus. Now, in addition to that, you could have various causes of vasculitis, but that's part of the anything in the brain. A vasculitis isn't part of anything in the brain. Trauma is part of the anything in the brain. Any of the infections. An infection in the brain burns the brain, makes it abnormality. That's part of the anything. Pus, purulent material, infected material, grubbing things together and causing electrical abnormalities in that brain. The meninges, setting up an electrical focus. Hey, wouldn't it make you run and have a seizure if I set fire to your house? How about I pour gasoline on your head? That's what the Zen masters say. The Zen masters say that a seeker of enlightenment has to seek enlightenment with such intensity as if his hair was on fire, as if there was a fire burning on the top of his head. With that level of intensity is the only way to break free. It's the same thing here. It's like a fire on top of your head. The only way it can make any of those things. Now, in addition to those things that are trauma and tumors and vasculitis, okay, the other part of it is that there are certain metabolic problems. And these metabolic problems that can cause seizures is either a high sodium or a low sodium. Now, either a high or a low sodium can cause you to have a seizure. A calcium problem, but calcium is low calcium causes you a seizure. Ready? Here's hypercalcemia. Hypercalcemia. Hypocalcemia. Ooh, twitchy. Hypo, low calcium. Ooh, tusos. Trustic, trustic, trusos, trustics, trustic, ooh, you got your trusos and my trustics. Your trusos and my trustics. Facial spasm, trustics. Carpal pedal spasm, trusos. Carpal spasm, not pedal, carpal spasm. Low calcium. Low magnesium, rarely low magnesium. How do you die of low magnesium? Actually, it's not a seizure. You die of low magnesium by an arrhythmia. Low magnesium causes a ventricular arrhythmia. Low magnesium causes a ventricular arrhythmia. Low magnesium causes a ventricular arrhythmia of Torsade. Well, what is a seizure but a psychological arrhythmia? A seizure is a CNS arrhythmia. Low magnesium causes a CNS arrhythmia. Low magnesium causes a uterine arrhythmia and premature labor. Low magnesium causes a ventricular arrhythmia, uterine arrhythmia. It causes a ventricular arrhythmia. Low magnesium makes things twitchy and hyperexcitable. Hypoxia. Neurons do not do well if they're dying of hypoxia. They cause arrhythmia, they cause seizure, they cause arrhythmia, they cause seizures. Drugs. Which drugs cause you to have a seizure? Good drugs. Cocaine toxicity, cocaine toxicity, cocaine toxicity, cocaine toxicity, cocaine toxicity causes you to have a seizure. Cocaine toxicity makes you seize. Benzodiazepines, toxicity or withdrawal? Withdrawal. Benzo and barbiturate, withdrawal. Benzodiazepine and barbiturate, withdrawal. Benzodiazepine and barbiturate, withdrawal. Cocaine toxicity, benzobarbiturate, withdrawal. What about alcohol? There you go. There's the 4 basic food groups for you. Alcohol, benzos, barbiturates, and cocaine. Alcohol, toxicity or withdrawal? Toxicity or withdrawal? And the answer is all of them. All of them. Either one. Either alcohol toxicity or alcohol withdrawal. Either one. Angel dust, phencyclidine toxicity. Phencyclidine toxicity can make you seize. Toxins can make you seize. What toxins? Cocaine toxicity, alcohol toxicity, phencyclidine, angel dust toxicity. Benzobarbiturate and alcohol withdrawal. Chloride doesn't make you seize. Chloride doesn't make you seize. Does potassium make you seize? Can you seize from a low potassium level? And the answer is you cannot seize from a low potassium level. A low potassium level cannot make you seize. A low potassium level cannot make you seize. You would die of an arrhythmia before you had a seizure from a low potassium level. You would die of a seizure, arrhythmia, before you died of a seizure, because cardiac conduction is far more sensitive to potassium. Cardiac conduction is far more sensitive to potassium. Cardiac conduction is far more sensitive to potassium than the brain is sensitive to potassium. High or low sodium, low calcium makes you twitchy and hyperexcitable. Low calcium causes twitchiness, hyperexcitable, arrhythmias, and seizures. Low magnesium causes seizures and arrhythmias. Hypoxia causes seizures and arrhythmias. Cocaine toxicity causes seizures and arrhythmias. Anatomic problems, including infection and vascular disease. And then the last thing it says is psychiatric, and that's called a pseudo-seizure. Pseudo-seizures, people faking their seizures. These are the etiology of seizures. If you have a person who's seizing and they don't have one of these problems, you then get an EEG to to see if they have epilepsy. Seizures minus correctable causes like this equals epilepsy. Seizures, but not a correctable cause, is epilepsy. Epilepsy is an idiopathic seizure disorder syndrome. Now, one of the things that can be difficult to distinguish is why a person loses consciousness. Now, on our next slide here, we see the description of what is the difference between a seizure and just having syncope. Well, to be precise with you, a seizure actually is a form of syncope. However, seizures as the particular type of syncope, how do I tell that they're not, say, cardiac syncope? Cardiac syncope doesn't leave you confused, no postictal. Postictal means your brain has been frying, you're confused for a while. Because there's no postictal period, they recover very quickly. These two things are really saying the same thing. If I'm postictal, I'm confused. If I'm postictal, I'm confused, I'm not recovering. The other thing is that people who pass out or lose consciousness because of cardiac things don't have incontinence and tongue biting and other fecal incontinence, urinary incontinence. So the difference between seizures and other forms of syncope is that seizures cause you to have a postictal period. Number one thing. People do not seize and go, hey, how you doing? I'm fine. I'm okay. People don't have generalized tonic-clonic seizures and wake up the next second. People have generalized tonic-clonic seizures go, person. So that's what we're going to do to distinguish between the other forms of syncope and seizures. When someone loses consciousness, the first thing is to say, did they really lose consciousness? People who lose consciousness with syncope, they can't hear things. They can't hear things. Could you hear things? Oh yeah, I could hear the conversations, just my eyes were closed. Well, they didn't lose consciousness. People who lose consciousness, they can't hear things. People who lose consciousness, they can't hear things. If you're passed out, you're out. You're not just sitting there listening quietly. So therefore, syncope. People who have syncope, one, loss of consciousness. Is it sudden? Or is it gradual? Now, a gradual loss of consciousness can be all those things that we said cause seizures, but not if they're complete enough to cause an actual full seizure. Now, syncope, the first thing after you have a loss of consciousness is the loss of consciousness sudden or is the loss of consciousness gradual? People who have a gradual loss of consciousness are the people who have those things that we said before could have caused a seizure, but didn't go all the way to actually having a seizure. In other words, people who have a hypoxia can cause a loss of consciousness. People who have hypoglycemia can have a loss of consciousness. Toxins and metabolic problems, they can have a loss of consciousness. Now, vasovagal can be either one, although vasovagal is often a gradual loss of consciousness. Vasovagal is, I feel shaky, I feel sweaty, pass out. A sudden loss of consciousness is basically two things. Is it cardiac or is it neurological? Is it cardiac or is it neurological? The second question is the regaining of consciousness. Is the regaining of consciousness sudden or is the regaining of consciousness gradual? And this was what we meant when we said seizures do not cause a sudden regaining of consciousness. If you're having a seizure and you go, you don't stop having your seizure and just pop up and feel great. People who have a sudden loss of consciousness, if they regain suddenly, that means it is a cardiac problem. Cardiac problems can either be rhythm problems or cardiac problems can be an anatomic problem, a functional anatomic defect. And anatomic defects are things like aortic stenosis, mitral stenosis, hypertrophic obstructive cardiomyopathy, rarely mitral valve prolapse. And the third question is going to be, what is the exam? So what we have done is we have just taken all the different causes of syncope that there is, and we have reduced it down to 3 questions. Is the loss of consciousness sudden or gradual? A gradual loss of consciousness is things that are toxic and metabolic things. People don't just walk down the street. I was walking down the street, just minding my own business, and all of a sudden I become hypoglycemic. Boom! No. People get hypoglycemic. I got a headache. Oh, I got to sit down. Oh, my heart's racing. Oh, I feel nauseous. I feel nauseous. I think I'm going to vomit. I feel so lightheaded. I feel so shaky and sweaty. I'm tachycardic. People who are hypoxic, you don't become hypoxic instantaneously like that. Sudden loss of consciousness, arrhythmias, obstruction, or seizures. If you regain consciousness gradually, you're postictal. If you regain consciousness suddenly, it's cardiac. Rhythm problems have a normal exam, and obstructive problems have an abnormal exam. That's why we get glucose levels, sodium levels, calcium levels, toxicology screens. That's why we get a CT. That's why we get an EKG. That's why we get the echo for me. That's why we get the CKMB. Also, let me give you the bottom line answer on loss of consciousness. 80 to 85% of the mortality is cardiac. 80 to 85% of the mortality is cardiac. Your basic mission in the evaluation of syncope is to rule out cardiac, because that's what you die of. You die of the rhythm, you die of the ischemia. And 10 to 15% of it, maybe 20, is neurological. So that means 90 to 95% of the mortality in syncope is cardiac or neurologic. What's the bottom line on a loss of consciousness for you? Rule out cardiac. Is it an arrhythmia, myocardial infarction? Rule out seizure. Seizures have tongue biting, incontinence, and a postictal period. Cardiac syncope doesn't. Now, after a person has had all of these causes of seizures and syncope excluded, that is when we finally get to doing an EEG. The EEG is what you do when you have a person who's had syncope and the initial evaluation has not shown it. In other words, the CT didn't show a tumor. There's no history of trauma. There's oxygen normal, glucose normal. I did my homework. Here's the bottom line. Oxygen normal, glucose normal, sodium normal, calcium normal, magnesium normal. CT scan is negative. Negative, 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 negative. Toxicology screen is negative. No history of trauma. We're done. Now you had all this done, then an EEG. EEGs detect occult forms of epilepsy. So our next slide is this, the EEG. After we rule out the physical causes, then we get these other tests, CT or MRI, or both. Because a CT might be negative, but an MRI will show something. Okay. Now our next slide here. Seizures on an EEG. Now we're showing you this EEG here to show you all these squiggles, but I guarantee you, if the one thing that step 2 will not ask you to do is read EEGs. We do this because we want to look like we're cool doctors, that's why. So we have this here to show you, don't try and learn how to read this. Don't do this at home, kids, because this is electrical activity from the brain, all these electrodes, and it basically says, well, let's see about petit mal. Something that's just a little bit bad. You see this petit mal thing here? Well, what this means is that the person who has a generalized seizure, when we have a seizure, we can divide up into 2 different types of seizures. We can have a partial seizure. Now, a partial seizure means just one part of my body is twitching and seizing. A partial seizure could be like, Frank Sinatra. Just one part. Oh, the shark has pretty teeth, dear. It's a focal seizure, partial seizure. Okay? But if he passes out, then it's complex. If he's still singing, it's partial, simple partial. Okay? If you're awake, it's simple. If you're awake. If he's still singing, it's simple. If he's passed out, it's a complex partial seizure. Ready? Simple partial. Complex partial. Or just one part of it. Now, simple seizures can become generalized. Can start out like this. Dum, 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 dum. Generalized. It can go from partial to generalized. It can go from simple to loss of consciousness. Complex means a loss of consciousness. Then there's generalized seizure. And a generalized seizure can be this. Generalized tonic-clonic is what Dr. Fischer has been making an ass of himself with all afternoon with you. Or, and we call that something, I mean, that's very bad. That's very bad. That's a big bad. Big bad. Grand mal. Big bad. But if you just pass out, like many of you do when you're watching videotapes. I'm sorry, what'd you say? That's only a little bad. And a little bad. And something that's a little bad, it's always sexier and fresh. Un petit mal. Un petit mal, un petit mal. And that is simply also known as an absence seizure. Absence seizure. I really like absence seizures because I can use it as an excuse for almost everything. It's not my fault, honey. I didn't take my ethosuximide today. It's not my fault. It's my EEG. What can I do, you know? I'm having absence seizures. How many attending physicians with attention deficit disorder does it take to change a light bulb? I'm sorry, what were we talking about? So the answer is, what was the question? Let's go fishing. Absence seizure. I just space out. Absence. I'm absent. That's also known as a petit mal. Tonic-clonic. Now you can have this, going to this, going to this. You can become it. This is the most simple thing, right? Simple partial. Oh, okay. I have a twitchy here, but I'm awake. Can become complex. Can become generalized. Now, EEGs, petit mal seizure activity. Next one, spike and wave. If you tell me there's spike and waves, I see the spiky waves. See, isn't that great? Wikipedia, good for almost anything. Okay? However, you don't have to read EEGs. You just have to know the point. These seizure disorders, you ready? Here's Dr. Fischer's handy-dandy cookbook for neurology. You're going to love this. Dr. Fischer's, put all this in the oven, bake it 350 for 20 minutes, and you can become a neurologist. This gets done on the first day. If this does not show the answer, you do this later on. And that's how you tell the difference in one way between a lot of the etiologies of these. Our next slide. Now, the first thing in therapy is the treatment of status epilepticus. Now, the treatment of status is actually the only true, clear answer for a person who has seizure disorders. If you have one of these underlying things, fix the underlying things. But the treatment of status epilepticus, the treatment of status epilepticus, the treatment of status epilepticus, lorazepam, or any other PAM, diazepam, lorazepam, benzodiazepine, diazepine. Okay, first. Benzos. Then if it doesn't work, and the patient says that they have received lorazepam and it did not work, the next best step, the patient comes with a generalized tonic-clonic seizure, receives lorazepam, but there is no effect. The next best step is phenytoin or fosphenytoin. And what's the difference between phenytoin and fosphenytoin? Well, remember that phenytoin is a class 1B antiarrhythmic. Phenytoin is in the same class as lidocaine. It's an antiarrhythmic. As such, when we gave phenytoin acutely, phenytoin was associated with hypotension, bradycardia. Acutely, phenytoin was associated with hypotension, bradycardia. Hypotension and bradycardia. It was associated with hypotension and bradycardia. It was associated with hypotension and bradycardia. Was associated with hypotension and bradycardia. Fosphenytoin, which is useful IV, does not have the hypotension and bradycardia. That's why we have fosphenytoin. Status epilepticus treatment is very clear. If that doesn't work, barbiturates, phenobarbital. Phenobarbital, acutely. And if that doesn't work, general anesthesia. Propofol, midazolam. Propofol, midazolam. Propofol and midazolam. General anesthesia. Ready? You're going to love this. You're going to love this. You're going to love this because there's nothing that's more satisfying to a medical student than to finally get one area of medicine that's completely clear. The guy comes in, he's seizing. I give him a squirt of benzodiazepine. It didn't work. I give him another squirt of benzodiazepine. It doesn't work. I give him fosphenytoin. It doesn't work. I give him phenobarbital. It doesn't work. General anesthesia and intubate. General anesthesia and intubate. And that's our story here. You ready? Let's look at these. Phenytoin or fosphenytoin. It's still continuing. It's still continuing. Time to intubate. Time to intubate. Phenobarbital, general intubation. Phenobarbital, still continuing, still continuing. Time to intubate. And propofol midazolam. Propofol midazolam. So, propofol midazolam. So, cookbook, cookbook. Now, let me tell you what's not so clear. What's not so clear is what to do about the treatment for people who have seizure disorders that are not a status epilepticus. First of all, you should not treat a first-time seizure unless you should only treat a first-time seizure. This is a very good question, very good question. You should not treat a person who's had only one seizure unless they come in and they originally were in status epilepticus. You should not treat a first-time seizure unless they have an abnormal EEG. You should not treat at a first-time seizure unless they have a strong family history of seizure disorders and epilepsy. This is the only time to treat first-time seizures. Status epilepticus, I'm not talking about that. The guy comes in status epilepticus and he's going like this. You don't walk up to him and say, "This is your first one?" And he goes, "That's not a yes." The guy's in status epilepticus, you don't say, "Is this your first one? It's your first one. I think I'm going to let your brain fry. I'm going to get some eggs and bacon and cook them on top of your forehead as your brain is frying." Status epilepticus always gets treated. But there's like a juvenile offender. You know, we have a first-time offender. Don't put them on long-term therapy unless there is status epilepticus, an abnormal EEG, or family history. Don't put them on long-term therapy unless there's status epilepticus, an abnormal EEG, or family history. Tonic absence seizures is the only one that's clear. Ethosuxamide. You ready? All the others, very unclear. Very unclear. It's very unclear whether it's supposed to be valproic acid first, whether it's supposed to be phenytoin first, or you add phenytoin, carbamazepine, or going on to lamotrigine. Not clear, boys and girls, which of these. And in fact, you can make a case for any four of them. I hate to say this, but you can't be asked definitely to choose. I'll tell you what you can be asked to choose. Ethosuxamide for absence seizure. I tell you what you can be asked to choose. Benzodiazepines, followed by phenytoin, followed by phenobarbital, followed by general anesthesia for status epilepticus. I'll ask you what you can be asked to choose. What are the long-term adverse effects of phenytoin? One, it can cause vertigo if it's in toxic amounts. It can cause vertigo and ataxia. It can cause vertigo and ataxia. Second, it can cause gingival hyperplasia in long-term therapy. What's very clear? Lamotrigine causes allergic reactions in the skin. Stevens-Johnson syndrome, toxic epidermal necrolysis. What's clear? Carbamazepine is good for trigeminal neuralgia. That's very clear. What's sort of clear? Which of these is the best one to use in pregnancy? Which of these is the best one to use in pregnancy? Sort of clear. We think that carbamazepine is the best one, maybe. However, this has never been randomized, prospectively studied, and it's still not super clear. However, if somebody puts a question on my test and says, you got to answer, I would say carbamazepine. So in reality, tonic-clonic seizures, the majority of people, 51%, would use valproic acid first. However, 15% might use phenytoin, 15% might use carbamazepine, 15% might use lamotrigine. So status epilepticus, very clear. Benzos, followed by phenytoin, followed by phenobarb, followed by general anesthesia. First-time seizures, do not treat unless they showed up in status, unless they have an abnormal EEG, unless they have a family history. Absent seizures, ethosuximide, that is clear. First-time therapy for generalized tonic-clonic seizures is not clear. What is clear? You're going to get big wonking gingiva with phenytoin. You're going to get toxic amounts, nystagmus and ataxia, nystagmus and ataxia. One of the only things that gives you vertical nystagmus. One of the only things, phenytoin toxicity, gives you vertical nystagmus. That's clear. So here we have seizure disorders. You ready? A person comes in and he's seizing. The first thing to do is to stop the seizure. The second thing is to identify a correctable underlying cause. Hypoxia, hypo or hypernatremia, calcium, magnesium, oxygen, glucose, anatomic abnormalities, toxicological things. You've excluded those things and you stop the seizure, EEG. Absent seizures, ethosuximide. Generalized tonic-clonic, long-term, don't treat them. Recurrent, and the answer is one of these drugs. Not clear. Most common adverse effect of lamotrigine, Stevens-Johnson. Gingival hyperplasia, this occurs at toxic amounts. Ataxia, nystagmus, vertical nystagmus. No treatment. Carbamazepine is good in pregnancy and for trigeminal neuralgia. I will see you in the next section.